in the Department of Epidemiology in the Milken Institute School of Public Health at GW, and I work closely with the GW Cancer Center and am honored to be helping to host this webinar. Today, we will be presenting Raising the Bar, how a small community cancer center is working to meet survivorship care planning standards. And we have two excellent speakers, Nicole Haynes and Tara Barker, both of whom are cancer nurse navigators and can each tell us a little more about themselves. The learning objectives of today's session include to learn how Mercy Cancer Center identified barriers and improvised strategies to meet Institute of Medicine recommendations and ACOS standards for survivorship care, to learn how Mercy Cancer Center integrates survivorship care into everyday patient navigation, to recognize the challenges and opportunities within a small community-based survivorship model, to discuss common challenges that a majority of cancer centers face in meeting survivorship care guidelines. Just a couple of housekeeping items before we get started. The webinar will be recorded and archived on the cancergate.org, which stands for the Generation and Translation of Evidence website. This is our second webinar featuring a survivorship program, and if you missed the first one, we encourage you to look at the archive. And the presenters are going to go ahead and do their PowerPoints, and after that we will open it up for question and answer. Given the large number of participants on the call, we ask that all the attendees please mute your phones so that we avoid background noise. You should be automatically muted, but please take that second step to double check. And you can submit your questions for the speakers via the chat pod or the question and answer pod, which are located on the right-hand side of the screen. And myself and other GW representatives will be fielding these questions for the speakers. So thank you to Canton Mercy for being a participating site in the Evaluating Cancer Survivorship Care Model study. And in particular, we'd like to thank Nicole and Tara for taking time from their busy schedules to share their experiences meeting the survivorship care planning standards. This is a topic that's of interest to many people in the field, as shown by how many people are here today. So please take it away.
Good morning and thank you. I'm Nicole Haynes. I am a cancer navigator. I've been with our cancer program here since 2009 and have been a nurse for 17 years. And I have with me here Tara, and I'll let her introduce herself.
Good afternoon. My name is Tara Barker. I'm one of the nurse navigators here at Canton Mercy, and I've been at Canton Mercy for the last 3 years. And since we are a small cancer center, I have been able to learn the roles of the various aspects of our cancer center, which has helped me learn how important survivorship is for our patients. So thank you for joining us today.
So I'd like to start by saying I did thanks so much to the GW for sending me a report of all the different questions that people had. There were a lot of questions that were written in, and we tried to incorporate as much as we could into our presentation, but we'll continue to answer questions and provide contact information at the end so that we can, of course, answer follow-up questions if we run out of time to answer all your questions today. We already discussed our objectives. A little bit about what Mercy is. Mercy Cancer Center is part of Mercy Medical Center, which is a community hospital of about 476 registered beds. We are COC accredited, and for 3 consecutive accreditations, we've received the Outstanding Achievement Award, which really makes us very proud in the process of doing our cancer care, because we do want to offer the best cancer care with the services that we have available and the resources we have. We do have radiation on site. We have infusion services on site for outpatients, and we have an inpatient oncology unit in the hospital. We also have a lot of affiliated community physicians. If you work for a community hospital, you completely understand that many of your physicians are not employed by the hospital, but they're in the community and they have a good working relationship. They sit on our cancer committee, and we sort of work together to achieve the common goals of accreditation and high-quality cancer care for the patients in our community. So I think everybody knows why survivorship. I mean, way back in 2005, the Institute of Medicine talked about this need for survivor care, and everybody agrees that's the right thing to do. Patients need to know what to do. Physicians need to know what to do, especially primary care physicians, because now there's so many people that are alive and well after cancer or living with cancer as a chronic disease that really need ongoing, lifelong care. So we all agreed. And the COC says you have to have it for accreditation. What we don't know is how we're going to make it happen, because it's like this huge mountain that we're all trying to climb. And I think everybody is struggling with this. So I don't think that we're experts at this. I think we're all struggling with the same journey. And if there's anything that we have learned during the process of our journey, we hope that it helps you. If there's anything you've learned through the process of your journey into survivorship, we're very open to what you've learned as well. So we decided that we had to begin somewhere. When the standard came out, said this has to be something we have to start working on, we thought we'd begin with benchmarking, talking to other facilities about what we're experiencing. What are you going to do? How are you going to approach this? And initially, the standard was a little bit vague as to who qualifies for a care plan. How do you define your care plan population? How are you going to do it? What programs are you going to use? All of that was very up in the air. So we started asking around, and we got a wide variety of answers, but mostly we just got mass panic in response. Nobody knew what they were going to do. Nobody knew how they were going to do it, especially because it's not really a reimbursable thing. And we all know in the world of healthcare, there are more jobs than there are people to do them. So how are we going to get it done? When we talked and benchmarked with all these other places that do what we do, we realized we were all in the same boat and none of us had a plan. So we decided we had to start somewhere, and we thought we'd do that by trying to find a really good trial population for our facility. Because we're a community cancer center, we wanted to start with who do we have the most contact with? So which patients do we have access to their medical records? Which patients do we see throughout their cancer journey? Which patients are really going to give us meaningful data collection in the future? Are there enough patients that they can evaluate our initial care planning process and give us meaningful feedback? So that's why, like most cancer centers that I have talked to, we started with breast cancer. First of all, it's a large percentage of our analytic cases every year. Many of them are treated right here with radiation. They have breast conservation surgery with their lumpectomies, and they get radiation. When that happens, we also are able to get some of their records from their other treating providers as part of their radiation consultations. So we have a lot more access to the information that they have on these patients so that their care plan can be meaningful and detailed. We also know that breast cancer survivors and breast cancer patients as a population are really engaged. They're joiners. They join the support group. They do so many things, and they are really good about offering feedback and advocating for better services for themselves. So we felt like it was a great target population to begin with. We also, through the radiation and infusion areas, but especially through radiation, we get to see those patients in follow-up. So it really gives us a great opportunity to see them on multiple visits, see how they're recovering, and schedule an actual survivorship meeting with them, because they're coming back for follow-up appointments, which sometimes in the community cancer center setting is difficult to find. There we go. The question, though, is whose job is it? Because we all know survivorship care is part of every member of the interdisciplinary team. It's everybody has to have a contributing piece. The primary care, the medical oncologist, the radiation oncologist, the surgeon, and the navigator, and any advanced practice nurses in an office all have a piece of the puzzle that needs to be contributed. But who's going to take the time to develop all of that input and put it in a way that people can actually read it through it, understand it, review it with the patient? And that's where we really felt that navigators played a really big role, because we do have a breast-specific navigator, and she meets those patients at the time of biopsy. She sees them before surgery and begins inputting data right away on what's going on with the patient. So we have a really complete picture between the pre-diagnosis all the way through to the recovery. We have a pretty good grasp as navigators of what is going on with the patient. But we also realize we have limited staff, we have limited time, and how are we going to fit survivor care plans that aren't going to be paid for, so therefore aren't going to fund another full-time employee? How are we going to get that in? First, I thought I'd talk a little bit about what our navigators do. And the reason for that is because I think every navigator I've ever talked to, although we all agree part of our job is overcoming barriers to cancer care, all of our facilities use us differently to fill gaps and needs. We have 2 site-specific navigators, a breast and a lung, and we have 3 general navigators. Now, that sounds like a whole lot of navigators in comparison with what some people have. But our navigators don't just do patient care and emotional support. We also address elevated distress scores. We address psychosocial and financial concerns, patient education, staff support, data collection, quality improvement. We sit on numerous committees. We're part of the palliative care team. And we also are cross-trained to relieve areas in the cancer center that maybe need a little extra coverage, whether it's going over to the infusion center and helping with medications administration and chemo and blood, or filling in for the radiation nurse and seeing patients on their office visit day, or the breast nurse helps with procedures in the radiology department. So all of the navigators are already stretched very thin. And so how were we going to make this work? Well, it's still a work in progress, honestly. So the first year, was 2012. We started benchmarking with other facilities, trying to figure out how we're going to do this. We actually looked at how are we going to input all this information, because our electronic medical record here at the hospital really isn't designed to produce a survivor care plan, and it really isn't designed for outpatient services. So we had to look at different forms, and we looked at a lot of the pre-printed templates that are out there from many different organizations. But again, those are all on paper, and at that time they were. And that was a real challenge for us, because the lung navigator, the breast navigator, and the general navigators, when we meet a patient, we can start inputting data on that patient, their diagnostic procedures, their physicians, their results, and begin building a survivorship care plan right away. But we can't do that on paper and hand that piece of paper off to another navigator and so forth. So we wound up initially using Journey Forward, which I understand many facilities are using. Journey Forward was very effective for us because we could download it on our computers, but we could save the documents in a common drive so that each navigator who interacted with a patient could help with the entering of the data. And so we did 8 care plans just on breast patients completing treatment and radiation therapy. Those first 8 care plans were done at the end of 2012, and we tried to just see how it went. Now, I know a lot of people wrote in on their questions, how do you get physician engagement? Again, it's challenging when you're in a community cancer center setting, because when your physicians are employed, you all have the same medical record system, and there's a lot more control to say, hey, this is part of your office's job now, you're going to contribute in these ways. We don't have that control over affiliated physicians. So what we really need to do is get them on our side, make sure they're in agreement, and the best way to do that is to show them how, one, it's meeting the standards that they too have to meet as part of an accredited cancer center's affiliation, but also that it's something good for their patients. So we started out with making a very thorough anonymous care plan in Journey Forward, printing it out, and then making a specific appointment with each physician who is primarily engaged with those breast patients, so that we could talk to them and say, what is your usual routine with follow-up? What is the most important thing that you think patients in their recovery and survivorship phase overlook? What are the things that you would love for us to reinforce to your patients or to their primary care? What are the things that you're worried are slipping through the cracks? And after doing that, those physicians who we as navigators already have a really good relationship with because we're helping their patients overcome barriers to care every day, those physicians were much more engaged because they had a say in how this survivor care plan would move forward. We even asked them simple things like, what's the best way to communicate your copy to your office? Do you want us to fax it to you? Do you want us to send it via an encrypted email? Do you want it in the mail? Do you use paper charting? How do you want to see this care plan arrive to you in your office? So that was our starting point. And so many of the breast physicians were very engaged because their patients are very engaged. They don't have a choice. They kind of have to be. The few that had objections, the number one objection to the care planning process was, but then my patient has all of these questions that they didn't ask before, and that takes a lot of my time. And there's good and bad to that, because from our standpoint, that's great. Your patients are asking questions about their follow-up care, and that's really what the goal of a survivor care plan is to help that patient advocate for themselves. But we do understand that the more information that person is armed with, the more likely it is that they're going to have questions. We know those questions about long-term side effects are addressed at the beginning of treatment, but those patients are overwhelmed just hearing the giant C word. They just heard they have cancer. They're not going to remember all those details. Having it compiled in one place may remind them about specifics that are concerning. And that's a place where we could offer reassurance to physicians. If the patient is significantly distressed over some component of the care plan that they're worried about in their case, once you as a physician have addressed the physician end of things, those patients can then come back to us as a navigator, and we will offer the emotional support. We will get the information. We will get the resources that they need to move them forward. We completed 114 care plans in 2013. Midway through the year, the breast process was going very well, so we added prostate patients who were getting their treatment in radiation because, again, another population that was pretty simple to capture and completed their treatment here so we could access everything. Now, that's 13.5% of our analytic cases for that year, which for us met our COC goal, but we wanted to do better. And I think all of us want to do better. We want to know that things are going to really be meaningful for the patient and that we're not missing patients. So in the second year, we decided in 2014 that we're going to add lung cancer patients. Again, this is a site we have a lung-specific navigator, so information about those patients is more accessible to us from the beginning, from the diagnostic phase. So we took those patients and we added them. If they're completing radiation or chemotherapy here in our infusion or radiation, we will complete a survivor care plan. Now, again, at this point, the COC was a little bit unclear about who qualified. So we had patients who perhaps were metastatic but stable, patients who had been around, had completed active treatment, were in surveillance but still had residual disease. And the question was, are these patients care plan appropriate? We weren't really sure, but we decided that instead of calling it a survivor care plan, we would call it a treatment summary and outline what they had coming forward. This was especially true with lung patients who, after treatment, sometimes would say, well, I'm done, so I don't need to go back, which isn't necessarily true. If they're done but they have residual but stable disease, they have a lot more that needs to be handled. So we did start sending out shorter, abbreviated versions of a survivor care plan called a treatment summary to those patients that were stable, but perhaps not disease-free. We began to come up with quite a challenge of identifying which patients really were care plan appropriate. We had to re-educate our radiation staff because they weren't really clear on who should be referred for a survivor care plan, and I didn't have access at that time to their records to look and see, okay, who's finishing treatment in the next few weeks. I had to rely on them for that referral. So the next step was to grant me access to their electronic documentation system because I am working closely with them because we are in the same department. It allowed me to be a little bit more accurate. So for that year, we did 95 care plans, which was 12% of our total analytic cases. Now, around that time is when Tara got to join us. And started to do some things with trials and help there, but also to help with some survivorship issues. We found that one of the first things we did was send out a patient satisfaction survey with each care plan because we really wanted to know, what does the patient think? Is it meeting the patient needs? We asked questions like, did you get the care plan when you needed it, too early, too late? Do you think the care plan, how likely are you to use it in facilitating conversations with your physician? Things like that. And I would say we got about a fourth of the patients sending back an evaluation. At this point, we were still meeting with patients in person and reviewing their care plans at their doctor's visit. Sometimes that would take as long as an hour and a half. Now, it took 2.5 hours to compile the information, an hour and a half to meet with the patient, And then that doesn't count all the time it takes to figure out who needs the care plans. And now we're looking at, oh, wow, we have to get expanding this, or we're not going to meet our accreditation guidelines. And there are a lot of people with diagnoses that really could benefit from having a survivor care plan. One of the things we decided was really necessary was improved software. Journey Forward has a lot of capabilities when it comes to importing data from perhaps registry and different systems and such. But what we really needed was, with our navigators, the ability not just to do care plans, but also track follow-up with patients, track other issues and data that we collected on spreadsheets up until that point, because care plans took a big chunk of our time. So we started using NurseNav software at the end of 2014 and into 2015, and that significantly improved our ability to get the care plans out in a reasonable time, specifically because it had a lot of template building abilities. So we could put in things that were important to our patients, to our physicians. And it also allowed for tracking of some of the things that we were tracking by hand, we could actually track through the program. The other thing that it really helped with was our Journey Forward care plans were very thorough. They met everything on the IOM fact sheet on cancer survivorship care planning, but the average size was anywhere from 12 to 26 pages. I don't know what they do differently in NurseNav, but I got to tell you, it's much more streamlined. Including the patient information that we add through templates, most care plans through NurseNav run the 4 to 5 pages. Some places are much leaner on the 1 to 2 page range, but we have found that the patients' concerns that we address are things that they've specifically referred for us to address, things they've specifically asked for, and patient satisfaction remains very high. Also, we want to make sure that our primary carers who are getting a copy truly understand the impact of the diagnosis and what resources may be needed for their specific patient. So we try not to overly streamline it, but at the same time not send a physician a novel through the fax, because they really don't want that. Our navigators collaborate very heavily. We still have to track who gets a care plan and when, and we work together to figure out who needs what, who's going to do which part of the care plan. The breast navigator maybe will do all of the diagnostic information, will enter all of the pre-diagnostic information. They will enter the distress score at their baseline and how they addressed it and what resources they referred to. Lung navigator will do the same thing. And the rest of us will do that with patients when we meet them at onset and continue to add in information as we go along. So we really do have to work very carefully together to track when these things get done. Tara, do you have anything you'd like to add about that?
I would just say that the software program called NurseNav is really an excellent tool for us to also cover each other and see what in real time what is going on to meet the patient's needs, so that you're able to just walk in and look at a patient's documentation and last interaction from another nurse navigator to understand what's going on with the situation to provide continued care.
Very good. So yeah, documentation is a huge issue in any area, but especially when you're in a community, because the community hospital, again, our software that we use for our electronic health record is not conducive to outpatient communication that we need. So by the end of 2015, we completed 292 care plans, which is 35% of our analytic cases. And we added all patients completing either radiation or chemotherapy for curative intent here on our grounds. Now, we also, those patients maybe got radiation here and chemotherapy in an affiliated physician office. We would still do that care plan because they got a portion of their curative treatment here. We also looked at adding in the third quarter all surgeries for curative intent, and that's a much bigger challenge because those patients only had surgery and really have minimal interaction with our cancer center. It does help if they have their cancer diagnosis pre-op and they don't find out about it at their first pathology visit at the doctor's office, because if they knew they're coming in for a cancer surgery, our navigator can round on them, let them know we have supportive services for survivors. We have support groups. We have exercise classes. We have massage and Reiki, and we have navigators to answer your questions, and we have Look Good, Feel Better that we host here in conjunction with the American Cancer Society. So we let them know about that, but also that they will be getting a survivorship care plan, and that the goal of that is to enhance their continuity of care and wellness into the future. So trying to see more surgical patients at the beginning is helpful, because otherwise when they get a care plan, they're like, I don't know who you people are. And we don't want the care plan, really the intent of the care plan is to help the patient, to help the provider. If it does nothing but cause anxiety for the patient, then it's not really doing its job. Now in 2015, one of the bigger challenges that we met is in doing all these care plans, surgical patients are not going to come back here on site for a one-on-one appointment when they don't have any other reason to be here for a survivorship visit. So we looked closely at the standard for how does the standard say this has to be reviewed with the patient. And the standard, again, on that point, said that you couldn't just, drop it in the mail without discussion. Again, we're a community cancer center. We can't tell a physician how to go about discussing survivorship care with their patient. We can't tell them in their office how they need to document in their EHR. But what we can do is complete the care plan here with their input, with the information they share from their office about the follow-up and treatment recommendations. We then decided we would start mailing care plans to the patients directly and doing a follow-up call and talking to the patient about their follow-up needs, making sure they don't have barriers, making sure they understand what their future needs and follow-up should look like. In addition to that, we send them a cover letter that says if they want to make a one-on-one appointment with the navigator at any time to review their survivorship care plan or answer other questions, they can call us. We very rarely, if ever, have that happen, but they do actually sometimes unsolicited call us back with questions as they move forward in their treatment, which to us says that's a very effective thing. If the patient feels confident that they can follow-up call us anytime during the course of their recovery and during the course of their survivorship, then we've met that area of need, and we're really happy about that they're reaching out to us. We also include in our fax cover letter to the physicians that we realize that they are monitoring their patient survivor care, and we have encouraged the patient to bring their care plan with them to follow-up appointments and review it with the physician. And I have had several patients tell me that they are continuing to do that, which is a wonderful thing to hear back. I've also had patients call and say, hey, I moved, and I just wanted you to know that this information helped transfer my care effectively to my new physicians. So that, for us, in addition to positive patient feedback through evaluations, really makes us feel like we're meeting the need. Of course, we're looking forward to the GW's survivorship study results to see if those patients who enrolled in the study actually feel that our process is effective. So now we've moved up to 2016, and the ACOS and COC, they continue to add these details to our requirements. One of those things is they have said that stages 1, 2, and 3 for curative intent, initial occurrence, completing treatment are appropriate for care plan. So that narrowed our field a lot, so we were able to start removing some patients that we agreed weren't really appropriate for a care plan. What that also does is, the registrar can help us in the sense that they can tell us what our analytic cases, what our stages are, but since those patients at the time that we get the reports from the registrar aren't done with their treatment, we do find that maybe they were stage 2 at diagnosis, but they had a MET occur during the course of their treatment, and now they're in chronic treatment. So now they're not appropriate for a care plan. We also look at patients like stage 4 head and neck who are locally advanced and treated for curative intent to have no residual disease, who is most likely to fall behind and get lost to follow-up. A lot of those head and neck patients who are very likely to recur. So although we're meeting the ACOS guidelines right now, we do continue to look at, are we really meeting patient needs if a stage 4 patient with no evidence of disease doesn't get a care plan, or a stage 0 patient who got the same treatment as a stage 1 or 2, such as in breast, would they benefit from a care plan? Because they're having the same effects, psychosocially, emotionally, physical side effects. So again, we're meeting our guidelines, but we're still looking at how do we meet the guidelines but expand to those other things. How do we make the time to do the non-required things that would really optimally benefit our patients? We do compare with the registry. Again, like I said, not all stage 1, 2, and 3 cancers qualify at the time the registry runs the report. The registry also keeps up with what's going on with the patient, but they sometimes are behind where we need to be just in order to accomplish the workload of care plans. So I would say it's very much a collaboration with the registry. They share information with us, and if we're the first to get the information, we share it with them. That also helps us not pester physicians unnecessarily for duplicate details. And, you know, doing that is very respectful of their time, and they appreciate that too. There are some patients who get partial treatment here at our facility, and then they get treated at another facility. So I have to make contact with those facilities and say, hey, are you going to do a care plan on this patient? And if not, would you please provide me the information I need to make sure they get accurate follow-up? If you are going to provide the care plan, do you need information from me so that you can make sure that they're getting what they need? We're also allowed to track refusals and no-shows of care plans. And those a lot of times are pretty minimal for us because we do get to make contact with all of our patients, either by phone or in person. But we do have a few now and then who either refuse to call us back, or the care plan comes back undeliverable, or any number of circumstances, or where the patient says, I've decided to transfer my care elsewhere and I'm going to pursue follow-up care and survivorship care with them, so I don't need anything from you. And that's okay. They can do that. So the navigators, again, we know our patients incredibly well. We're involved in diagnosis, and we also are really good at knowing what our patients' follow-up needs and risk factors are. We know the supportive services in our area. We know what our patients need, what they qualify for, what we've referred them to in the past, and we also, in our treatment areas, do end treatment distress scores. So we know at the time they finish treatment, we know what they were worried about. So we can really tweak their care plan to meet their needs and be very specific with our follow-up call about things like smoking cessation, weight management, finances, insurance, employment, other things that maybe their physician's office, while addressing their physical side effects of treatment, may be less equipped to address.
One of the areas I wanted to mention is how we find our patients. And in our inpatient medical record system, we have worked with our IS department to be able to track patients by putting a cancer indicator, whether they have a cancer or a lung cancer, or if they're a clinical trial patient. And that way we can run reports on a daily basis to track where patients are. And how we get to that spot is we actually review every single pathology that comes through our hospital, and our registrar is very good at delivering us a stack of papers that has every new pathology on a daily basis. So one of the navigators can go through those patients and compare with the information that we may already have on that person to get them registered in our nurse nav system, to follow them through and plan accordingly to where they are in the cancer diagnosing process and treatment.
And that's a real help because, you know, when you have patients coming and going all the time, being able to identify when a patient returns for an additional workup is huge in developing the navigator rapport. Even if they don't need a care plan, developing that rapport for that time when they get to end-of-life decision-making and really need to sit down and have a heart-to-heart with somebody, by the time they've been in the hospital numerous times, we've really seen them a lot and have opened up a lot of dialogue. So it is really, it's really very helpful in that sense.
Yeah, so for example, we track like if they come in to have a blood transfusion, that will come up on our report, and we can touch base with that patient when they come into our infusion center. That way, you know, we can establish that long-term relationship so that in the future, if end of life or any kind of referral needs to happen for palliative care or any kind of long-term management, we can kind of help facilitate that for the patient.
The other thing is that also allows us to start talking about survivorship. I see a question from this morning. The software system we use is NurseNav. There are others. And I do not know about Epic compatibility because we're not on Epic. But the main challenges that we have faced, in addition to just the time, the overwhelming amount of time, is obtaining information from all the offices that participate in a timely manner. Over time, we develop a process, getting to know the staff at the physician offices. They get to know us. They know why we're calling. Oh, it's you again. You need information for a care plan. But it's still time-consuming to call all the offices that may be involved and for them to usually fax us information. We've made fax form follow-ups for simple follow-up where they can just check boxes, which a lot of the offices appreciate because that's a quick thing. But there are some things like chemo regimens we need a lot more details about, and it's not a checkbox. It's a medical records person that maybe we have a good contact and we call them directly.
So we also track all of those resources at various facilities, whether it's a tertiary care facility or another, specialty location. So we track those specific contacts in our NurseNav software so that all of the nurse navigators can have access to finding those specific resources.
Yeah. We do find if you are looking at software that having one person maintain the contact list avoids duplicates. And really makes a big difference in how you communicate effectively, because sometimes there'll be duplicates or inaccurate information in a contact, or a contact changes, and if you have multiple people going in and out of the contacts, it just makes for a lot of errors and miscommunications. But anytime, as a navigator, you get used to making 25 phone calls to get a resource. So anytime that we identify a good go-to person, we put all of their contact information in NurseNav and make sure that a person can look that up in our contacts and that we know who to follow up with. And if we know a patient is going to explore options at a facility that maybe is particularly challenging to get information on, we put that in our notes. This person's going here, so when you do a care plan, you may need to contact so-and-so. So we really do work hard at that. I think one of the biggest challenges is tracking all those pathology reports, because we get about 350 paths a quarter, and maybe 130 of those wind up being care plan appropriate, which is still a lot when you're talking about not having a full-time employee dedicated to doing that. But it's a lot of tracking to find out someone really doesn't qualify for a care plan. However, a lot of those patients wind up dealing with us anyway. So we get to know them, we get to track them in our system, see when they come back, and be supportive for that. The other thing that we really find challenging, and if anybody has any way that they're doing this, is once the Survivor Care Plan has gone out to the patient, the goal is that that be a living, breathing document. And how do we make that happen when we're distant from the patient, when they come to us for supportive services, but their care is spread out over multiple community providers? The living, breathing document part is really a challenge. We encourage patients to update it, and if a patient resumes treatment and asks for a new one, or if they get a second primary, but it's very curable, we will amend our care plan and give it back to them again with those updates. But really, it's very, very challenging to see how, moving forward, we make that an active part of their ongoing care. One of the opportunities we, of course, enjoyed was participating in the GW survivorship study. Our patients really were very excited about participating and about giving their feedback, which made us very happy that they were able to do that. We also are grateful to be in a community setting because despite all of its challenges, being a community hospital means you're very connected to the people around you. It's a smaller community. We get to know people really well. They get to know us. They see us at health fairs and community events, and they talk to us. And we really get to know what's going on in our community and the surrounding counties so we can offer support from beginning of their cancer process all the way through into survivorship or whatever the next step is. Which leaves us with the remaining challenges. We do this great job of meeting the standard as far as or we think we're meeting the great standards. We're not really sure. It's still a work in progress. But sometimes we wonder, is this really what the patient needs to know? is every patient really going to need this care plan? If you have a stage 1 colon cancer that was resected and they're 94 years old, do they really want a 4-page care plan telling them about surveillance? Are they really going to do cancer surveillance? Or are they just going to be grateful that they had recovered well from surgery? When does a patient need to know it? With our breast patients, we found waiting till they were done with Herceptin was not ideal because they didn't see themselves as still in treatment. They wanted their care plans early. So we went back to our cancer committee and said, hey, we know we said we would do it at the end of the Herceptin year, but really patients want it at the end of the chemo when they're in their maintenance Herceptin. So cancer committee agreed. Patients want that earlier, let's give it to them earlier. Is it the most effective manner to get the patients their information? Maybe, maybe not. We're hoping that GW study reveals more of that to us. And again, making the document a living document is a huge challenge because even if it's electronic, when you're printing it out, are you just printing out a progress note and handing it to the patient? What is it that we can really do to make this a living document, a part of their ongoing and successful and well future? And I think that is it. So we're both open to any questions you might have. We'll scroll through our Q&A. I see a Q&A that when is a patient eligible for a care plan? We do patients who were not diagnosed at our facility if they had a portion of their curative treatment here. So let's say they had a biopsy in the office, identified a cervical cancer. If they have surgery or radiation for their cervical cancer with us, we will complete that care plan because most likely their oncologic gynecologist is not going to be doing a care plan from the office. So we will contact the office, get the information, and provide them with a care plan. A patient we consider eligible according to the standard, I believe it's 6 months from end of treatment or a year from diagnosis, assuming that that patient finishes treatment in that window. So with all those patients that we're tracking, we are looking all the time to see where they are in the course of their treatment so that we get it to them within that 6-month guideline. And sometimes, honestly, it's a little close when we're really swamped with other responsibilities. But we do try very hard to track their dates and keep in touch with those offices about, hey, are they done yet? When are they projected to be done? And again, we do stage 1, 2, and 3 who are being treated for their initial occurrence with curative intent, any component. Even if they had a biopsy here and all their treatment, let's say it's a lymphoma, all their treatments took place as chemo in the physician's office for curative intent, if that physician is affiliated with our cancer center as part of our team, we take the responsibility of completing that care plan. The physicians, some give the care plan to the patients. For instance, if we don't have a current mailing address, we currently started mailing to the patient. And we mailed to the patient with the intent that they would discuss it with their physician. Many patients tell us they are discussing it. We also fax the physician the copy, all the physicians, with the encouragement to follow up. And the navigator actually talks to the patient right away after receipt of the care plan, reviews it over the phone, offers a one-on-one appointment. And then, yes, a lot of the physicians, I've had patients tell me that their gynecologist reviewed the care plan with them at their follow-up appointment, or that their oncologist discussed their survivor and follow-up needs and made sure they had a copy. So it's sort of double duty, but we'd rather it be that than they get missed and not have one. Patients with recurrence. Currently, the guidelines say that if it's their primary, and excuse me for leafing through my paperwork here, but according to standards 3.3, it is patients who are stage 1, 2, or 3 treated with curative intent for initial cancer occurrence and who have completed active therapy. That's what's required by the COC standard. So we are making sure that we meet that requirement because, honestly, we don't have the resources to do above and beyond that. The COC does allow for wiggle room, though. So if a patient with a recurrence is treated for cure and really has had a care plan before and is interested in having one again, we absolutely would do that for that patient. Or if it's a patient we recognize needs some additional TLC, needs some help not getting lost to follow-up. So that portion of it is flexible, but we make sure that at the very least it's all the ones required by standard 3.3. The specific data elements that we collect pretty much everything that's listed in the IOM fact sheet from 2005 that includes a record of care, what they had, the dates that they had it, any resources they needed, what their recommended follow-up should be, both by their physician and by their primary care, and then supportive resources for them. The navigator does give the care plan to the patient, whether it's in person or by mail. And again, a lot of them are by mail, although if the patient's agreeable to coming for a follow-up, we do it in person, and we discuss it. The primary care gets a copy and is encouraged to also follow up with that. It's our goal this year we've surveyed patients, we've talked to oncologists, we've talked to surgeons. This year it's our goal, now that we've had enough care plans go out to a variety of primary cares, it's our goal to evaluate the process from a primary care physician end and see how satisfied they are. We do have financial counselors, and they primarily do the inpatient component of helping with getting them linked in with Medicaid and things like that. But the navigators actually do a lot of the outpatient. We help with prescription assistance. We help with applying for Social Security disability. We help with helping them apply for copay programs. And we facilitate connecting them with a financial counselor in order to apply for hospital charity programs and Medicaid. As far as information on Journey Forward and NurseNav, we'll have our contact information at the end. So if anybody wants to email us specifically, you're welcome to do that, and we can share what information we have. Okay. We don't have any outpatient social workers. So our social workers are inpatient. They're a great resource when I need to set up home care and have questions. But generally, our outpatient navigators sort of dual function as a social worker. We actually do a lot of helping patients with their social needs, whether it's referring to support group, counselor, psychiatrist, mental health issues, financial issues, homelessness, all of that we generally take care of. As far as the data vetting, for patients who are eligible versus who had a visit and is all that data vetting is all manual. We do get a report of positive pathologies, but the actual vetting of the data is all manual. We have yet to find a way, since we have affiliated physicians with their own electronic charting systems, we have no way of really truly getting access to their records outside of an inpatient stay. So it requires us to call, fax, beg, plead, and email, whatever it is that we need to do with those offices to communicate effectively. But that is all manual data tracking, and that pretty much Tara and I do. And it is a huge undertaking. Sorry, we're still scrolling through your questions.
This is Mandy Pratt-Cutman with the GW Cancer Center. Thank you so much, Nicole and Tara, for doing this very helpful webinar and sharing all of your information. I know a number of questions have come in, and I'm sure you're swamped with the number of questions rolling in, but there's been a number asking about the mailing process, given that COC has said that mailing doesn't meet the standard unless the patient refuses the in-person visit, in which case it comes off of the numerator and the denominator of things. So could you respond to this last question?
Yeah, so we have thoroughly been exploring this whole mailing issue because, again, we have a lot of outlying areas. We have a lot of patients who don't come back to our facility for the delivery of the care plan. So when looking in the standard, I actually have it open in front of me, sorry. But what the standard has said is that mailing the care plan without discussion with the patient or giving them a link to your electronic portal is not acceptable. And we agree. That's crazy. That's not acceptable. But through our Cancer Committee and review of the standard, the Cancer Committee has decided that the physicians feel they want to be the ones to discuss the care plan with the patient, but they would like the patient to have that copy in advance. So we do mail the care plan to the patient, and the navigator calls, discusses, confirms receipt and answers questions and offers the patient that one-on-one appointment. If they refuse that one-on-one appointment, that is okay because they're still going to have their follow-up with their primary treating physician, and that physician is then tasked with the responsibility of discussing the care plan in more detail and their survivorship care. The challenge for us is that because those physicians have their own electronic health records, we have no way of verifying that anything got delivered or that the conversation took place. We don't have data to produce because we don't own their medical record. So our sending the care plan and having the conversation is more of a double-check system, really, to make sure that the patient got everything that they needed and that we were made sure that they have the opportunity for an additional one-on-one appointment, that they have the opportunity to get those questions answered, and that their physician is talking to them. But we can't prove that through a data collection because we don't have access to their records at their physician's office for ongoing follow-up. That would, again, be a manual data collection. So at this stage of the game, we are making sure the patient gets the information, having very good conversations with them, and through Cancer Committee, having the physicians on board that, yes, we are on an ongoing basis going to discuss this survivor care. And so it's more of a multi-phased process for us. Now, we don't know. When the surveyor comes, they may say that makes perfect sense in our situation because the patients don't return here to a large degree unless they're using a complementary service like the massage, the Reiki, the support group. They usually talk to us by phone about their ongoing needs, supportive needs. So we're hoping that the COC sees our very sincere effort to meet the patient's educational needs through the care plan on multiple fronts. And that allows us to track data that proves, yes, they got it, and yes, they had a conversation. But that does not replace the physician conversation in the office. So that's where we're at. Now, hopefully we'll have our survey at the end of the year. We continue to monitor the COC website for updates and FAQs and all of that to see if there is a way that they are saying absolutely not, that this is totally and completely inappropriate. And if we see that in writing, we'll have to revisit our whole process. Probably not the process of how we get the care plans done, but the process of delivery to the care plan. And how we would track that, I don't know. We would have to really look at it. It's a whole different world in the community cancer center versus a cancer center that has all their providers under one roof and all their documentation right there, and you can point to it and say, look, here it is, we did it. Here, that's a real challenge to be able to do, to make sure all our bases are covered. But that is the goal, that the patient is talking with their physicians, that the patient is talking with their navigator, that the patient physically received a copy, and that they didn't get that copy with no conversation about it. I hope that answers.
Yeah, that was really helpful. I'm just curious, you may have covered this at the beginning, and I'm so sorry that I missed it, but which division or what part of the cancer center are you housed within? Are you in a complementary therapy or a separate department, or are you in HEMONC, or?
We are in in the main hospital. Our entrance is the surgery center and breast center entrance, and we have radiation therapy, infusion therapy all right there, and our navigator's offices and our trials offices are all right there, so that the patient doesn't have to walk far into the hospital to get the services that they need. But our physicians have community offices for the most part. There are a few surgeons, a few primary cares who have offices on campus in our medical office building, but the vast majority are scattered throughout our community and multiple counties, in fact.
That's really helpful. That's for context. Thank you so much.
You're welcome. I see a question that says, do we know from the COC if an effort in the right direction is acceptable for credit for the standard? I will tell you that in our past experience, as long as we can explain how our process fulfills the standard as written, we have to have good reasons for doing things the way we do them. And in our experience, that's what the COC is looking for, is are you meeting the standard, and can you explain why you're doing it the way you're doing it and why that works for you? So I think that anytime you make a decision about how you're going to address a patient concern, a COC concern, a data tracking concern, you need to really have good reasons for the process that you have and be able to demonstrate that it's working for you, whether that's through your completion data, your patient and physician satisfaction data, any of that. So if you can speak to why you do things the way you do and how, in your cancer committee's view and your understanding of the standard, that meets the standard, then the COC has been very agreeable with that approach, because obviously every cancer center has to handle things based on how their community and how their process and how their physicians are set up. We don't have the resources of a huge university. We have what we have. So we can't have a survivor clinic. We don't have the census and the power to do that, or the funding right now. So our way of approaching survivor care is certainly going to be different than a large facility who has all of that. So if we can justify why we've chosen to do things that we're doing and how they meet the standard in the context of what we do, then that's the best that we can do, and we will find out when we get our next survey. But up until now, our efforts have been appreciated and recognized by the COC, and we're grateful for their understanding of how our process meets patient needs.
Nicole, thank you so much. This is Mandy again. I'm looking at the time, and you've had such a huge audience with this webinar. We had over 500 registrants, and I think I saw 327 people on at one point. So, and I know there's a lot of questions that you've not been able to get to. I'm wondering if we compile and consolidate the questions, and some of them are very similar. Would you and Tara mind answering them, and then we can circulate them to the participant or the registrant? I think that would be really helpful to them.
Absolutely, and Tara and I posted our email addresses, so please feel free to reach out. We're happy to discuss the process, and I'm sure there's a lot we can learn from all of these people who have been so kind to take their time to listen to us jabber on about it.
Well, thank you, and I encourage you, if you haven't already worked with Hema, to post something on our Cancer Gate in terms of your insights here, which are invaluable. And for those who are registered for the call, to take a look at our CancerGate website, cancergate.org, where we are aggregating practices and research findings to try to help you with this work. So this is our contact information, a way to get to the CancerGate and follow us on Twitter. And we will be sure to follow up with you. Hema will follow up with you with a Q&A document so that you have some answers to the questions we weren't able to get to. And Nicole and Tara, thanks again for your generous giving of your time. Hannah, thank you for being here and also representing for our team on this webinar.
Thank you so much.
All right. Have a great afternoon.
You too. Bye-bye.
Bye-bye.